From the moment of entering this world, with its silver years, with challenges of a different kind, to situations of trauma when the entire family needs support. Over 300 specialist doctors across 50 specialties cater to patients from the region, other parts of India and overseas. When genuine care meets state-of-the-art technology, one certainly feels better and then heals better. Kauvery Hospital, a trusted name in healthcare. With 5 key centers across Tamil Nadu, Kauvery Hospitals offers clinical excellence and world-class infrastructure in a myriad of disciplines. There's a 24/7 imaging services and a futuristic cath lab.
Are you able to hear me well, Ms. Sujata?
Yes, I can hear you.
Better? Is less echoing?
There's a light echo, yes.
Okay. I think there's a problem with the earphones, so is it there? Give me some.
No, doctor, it's now fine. It's now fine.
It's not fine?
It's fine. It is fine. Yes.
Okay.
Jata ma'am, we can start.
Okay. Good morning, everyone. Welcome to the Hindu Wellness Series webinar on stroke emergency and rapid response. We have today 3 eminent panelists, Dr. Bhuvaneshwari Rajendran, Dr. Sivarajan Tandishwaran, and Dr. E.S. Krishnamurthy. Dr. Bhuvaneshwari Rajendran will speak on prevention with special emphasis on COVID and stroke risk. Dr. Bhuvaneshwari has spent 12 years in London. Can I start?
Are you able to hear me well?
Yes.
I'm Dr. Bhuvaneshwari, neurologist at Kauvery Hospital. For this year, we are talking about stroke awareness, increasing stroke awareness, and as part of that, Hindu this prevention. So if you look at the stroke incidence around the world, the WHO actually states that almost 15 million people can have stroke every year. And out of the 15 million, about 5 million people have permanent disability. And about 5 million can even. Now, this is not a good state that we want to be in because we know stroke is treatable. So, it's important that identify early hospital where to get treatment ASAP to prevent disability arising from brain damage. Now, looking at stroke, what are risk factors? So, if you look at risk factors, patients could have diabetes, high blood pressure, obesity, or level, their lifestyle and genetics of incidents, especially in India, the genetic part, of course, plays a role apart from your lifestyle and also other treatable factors like diabetes and hypertension. So it is very, very important under, especially diabetes and hypertension, we keep we lead a healthy lifestyle. Our diet should be balanced, and we should make sure that we lead a very physically active lifestyle. In fact, the Stroke Association of the World this year have brought in a slogan called "Join the Movement," which means be as much as active as possible so that you can prevent strokes and heart attacks. Now, we that many country like India, because if you look at the incidence, the age of stroke would be after 50 years or 55 years. That's the kind of age group that you're looking at amongst the Caucasians and Europeans. The and hypertension, your lifestyle diseases, what is play a role. And we also have factors like coagulable states. You know, these patients have higher blood coagulability tendency. So as a result of which younger patients can have stroke. So when we see young patients come to the hospital with stroke, apart from the regular risk factors like diabetes and hypertension, we also look into the other risk factors, especially looking at the heart. We want to make sure that there's no congenital heart disease, valvular conditions, rhythm problems, because when your heart rate is not regular, the blood flow through the heart is not clear and you don't have circulation in the heart, which can get dispersed in heart strokes. There are certain people who have higher tendency to heart formation. Now, these are patients that we need to be looking at to reduce the risk of getting strokes. And of course, one big factor, hypertension. Now, we know, and also diabetes. Diabetes and hypertension, again, are two diseases which we are seeing earlier in our country than in Europe or amongst the populations. So, let's actually look at how can we prevent stroke. What do we do? So keep your diabetes under control, keep your blood pressure under control. If there is a strong family history of strokes or heart attacks, please make sure that you check yourself from time to time. You do not ignore certain simple warning factors like headaches or if you're drinking too much water or putting on weight. These are factors we should be looking at to listen. There is a stronger family history of strokes, especially in a country like India. Finally, when we are looking at the risk factors for stroke and especially in a country like India, we cannot forget the fact that we are in a pandemic right now. Now, apart from the regular risk factors for stroke and including the high prevalence of young strokes in the country, suddenly during this pandemic, we have started seeing younger patients come in with strokes, especially involving the larger blood vessels. And when we look at what is the sudden, why is there the sudden surge in the younger strokes, we find that COVID infection, we We are hearing so much about the cytokine storm, the immune system reacting to the infection, increasing your susceptibility to lung infections. Similarly, the immune system is causing increasing clotting inside the blood vessels in these patients who are affected by COVID. And as a result of which, we are seeing young patients come in with strokes and heart attacks. And this is something we are keeping in mind when we are seeing younger strokes now in the hospital. So I think it's very important to understand where we stand in terms of our family history. Look at our background for problems, like if there is a high incidence of diabetes and hypertension. Please look at your lifestyle. Make sure that you are leading a very healthy lifestyle. Your food habits are balanced, and your your approach to life should be more on the positive note. And also, as I said, as the World Health Stroke Association is calling for join the movement, let's join the movement. Let's keep ourselves physically active. And I think my colleague is going to be talking to you about what we can do if a patient presents to you with acute stroke. Thank you.
Thank you, Doctor. Thank you very much. Next, Dr. Sivarajan Tandishwaran will speak to us on treatment and complications. Dr. Sivarajan had higher specialist training in stroke medicine, general internal medicine, and gerontology at Oxford Deanery, United Kingdom in 2002. He has a clinical fellowship in stroke medicine, neuro-rehabilitation, and neuro-intensive care from Oxford Deanery. He is a consultant in stroke medicine, general internal medicine, and gerontology at the Oxford University Hospitals NHS Trust. Dr. Sivarajan's specializations include stroke medicine, neuro-rehabilitation, neurosensitive intensive care, general internal medicine, and gerontology. Neurovascular interventions for hyperacute stroke, stroke prevention clinics, and spasticity management. He's also an expert in advanced MRI imaging and research. His interests include acute stroke, neurodegenerative disorders, neural plasticity. Thank you, Doctor, for being with us. I request you to please start your.
Thank you so much for your kind introduction, madam. And it's a pleasure to be invited to talk in this meet organized by Hindu Wellness Series. And many thanks to all the panelists. Bona has given a very good start with a very clear introduction on all the risk factors to stroke and how to prevent and avoid having a big stroke. And I'm also very grateful to talk along with Dr. E.S. Krishnamurthy, one of the stalwarts in neurorehabilitation and psychiatry. So let me start by saying tomorrow we are going to observe the World Stroke Day. And yes, Varmun Kapam is very important in preventing a stroke. And once we have a stroke, what do we do to try and reduce the burden of the stroke? That's the key talk I'm going to spend the next 10 minutes. Let me go to the next slide. Okay, so we all know that time is gold, but we like to say that time is brain because brain is a very, very specialized organ. It's densely packed, intricately patterned substrate of our mind and awareness. The human brain is a wonder of nature. In an acute stroke, vast numbers of neurons, synapses, and nerve fibers are irretrievably lost every moment in which treatment does not occur. So as you can see in this slide, every second we lose about 32,000 neurons. And in a minute, we would have lost almost 2 million neurons as soon as the stroke starts. By the end of a stroke, almost 1.2 billion out of 130 billion neurons in your brain is destroyed. And the person is said to have aged by at least 36 years, and they have to start everything fresh when they start to have rehabilitation. So with that note, I would like to go on to what happens immediately after one gets an infarct. So as soon as the area in the brain is starved of blood flow or glucose and nutrition, we have a core that is irreparably lost, that we call as infarct, or the core of the stroke. And around the core, there is an area which is blue in color on the slide, which is called as ischemic penumbra. I'm talking about ischemic strokes. These are the commonest type of stroke. Almost 80% strokes are due to a blockage to a blood artery. So what we try to do in acute stroke scenario is try and minimize the damage to the penumbra and recruit as many areas as possible to reduce the stroke burden. So as soon as the stroke starts, you can have a small core with a reasonably large penumbra. As time goes on, in the next 4 to 6 hours, you can see the core expands into the penumbra. And when a stroke is complete, say about 24 hours, the whole penumbra is infarcted, and there is no way of repairing the damaged brain. Unfortunately, the neurons are not regeneratable. Like when you cut your hair or nail, it can grow back, but nerve does not grow back. The brain will not be able to grow its own cells. So we have to rely on plasticity. So looking at the scan where a patient did not get any treatment in the first few hours of the stroke onset. So what you see on the screen is a CT brain. On your right-hand side is the left side of the patient's brain, and the right-hand side of the patient's brain is your left-hand side. So you can see on the left side of your screen, you can see the brain is slightly swollen at about 2 hours. And as time progresses, you can see the brain is changing its nature. So you can see a smudged area on the whole of the right brain. So this type of scan confirms that the stroke is complete and we cannot repair this brain. So as Dr. Guna said, stroke is becoming very common, especially in young population, unfortunately. And this has become the second most common killer amongst all non-communicable diseases in India. So the statistics from India sort of extrapolate like 15 lakh people are affected by stroke any given time point. And almost 6.3 lakh deaths happen every year. And out of that, almost 40 patients do not survive from the stroke. And it also adds enormously to the disability life years. Almost 64 lakh life years are lost due to disability in India itself. So why do we worry about stroke that much? So stroke carries a very high mortality. Even in the best centers in the Western world, it has about 10% loss of life or death rate in the first month after stroke, with the best stroke units and the best interventional care and so on. So it also has a lot of impact on the age and also sex. So anyone who's in their early 40s, 50s, 60s, the risk of dying in the first few weeks is a little lesser than somebody who is about 80 years age. So in this graph, you can see the top line on the age side. You can see it's the 0 to 64 age group, and the bottom line is the more than 85-year-old age group. As you can see, the first few months after stroke, almost 30% of 80-year-olds a person might lose their life, and by 7 years, pretty much most of them are not alive. So, and the same happens with the stroke severity. So we do see strokes at various severity scales. The NIHS is one of the stroke scales we use. Less than 4, we often say it is a milder stroke, and anything more than 16 is a very large stroke, which causes significant disability. Those who come in with a large stroke, so going back to the previous slide where there was a small core and the penumbra was gradually getting lost. So that is what we want to do. We want to make sure everybody is in the milder stroke category and not growing into a large stroke category. So if somebody ends up with a large stroke, almost 60% of them are not going to be alive in the first few months itself. And again, if you look at the stroke subtypes, there are, as I said, I'm just giving data on ischemic strokes or strokes due to blockage in the blood-brain vessels. So if it is a clot coming from the heart or the large artery in the neck vessels like carotids, they have a higher stroke burden. And if it is due to a smaller block within the tiny branches in the brain, often called as lacuna strokes, they tend to do better. So having all the technology to identify what stroke someone has is very important. And so you can direct your resources in rehabilitation and subsequent secondary prevention. So until about, say, 25 years ago, it's been almost 25, quarter of a century until we had a landmark trial that showed us that there is a treatment available for stroke. So when I was in medical school, we never had any opportunity to treat our stroke patients with the latest treatment. So most of them were left in a corner of a ward with rice tube feeding, and also IV drips for a day or two, and they were bedbound. They tend to develop bed sores and aspiration pneumonias, and the death rate and the mortality was extremely high. So everything was changed with this landmark trial from 1995. So this drug has been in use for heart attacks for a very long time. So the thrombolysis, the clot busting drug that was used for acute heart attacks, was trialed in stroke patients, and they found that it was able to reduce the stroke burden if it was used in the first few hours of the stroke onset. So across all scales of outcome index like Barthel, Rankin, Glasgow, and the NIHs, there was a significant reduction in disability and a better outcome. So within the patients who actually had the drug, the numbers who had better benefit was much higher in the first 1.5 hours compared to those who came late and had the treatment much later in the 4.5 hours. As against, the benefit outweighs the risk at a very large proportion in the first few hours. As time goes on, the risk of bleeding, which is seen in the red bars, gradually rises from 1.3 to 7.1% of those who had the drug. So that's the key message that I want to get across, that when the stroke happens, we want everybody to identify it promptly and come to a stroke-ready hospital so we can give you the right medicines at the right time. So coming late towards the end of the time window does not help you that much. So you have to rush to a stroke-ready hospital as soon as possible. So in this scale, it just clearly shows the risk, the odds ratio of someone getting a better outcome at 30 days is much, much higher compared to coming at a very later time point. Beyond 4.5 hours, there is not much benefit in using this drug, and the bleeding risk increases. So in a setup like our hospital at Kauvery, what do we do? So we run a very efficient hyperacute stroke service. We have very clear guidelines on what to do in the first 30 minutes. So as soon as a patient comes, even before the patient arrives, the ambulance crew would pre-alert the emergency room. As soon as the patient arrives, they have a very focused neuro exam. Time is not wasted in checking all the other systems and so on, like checking your tummy or checking your heart or lung. And we just want to make sure what sort of stroke it is in the first few minutes itself. So immediately bloods are taken up, lines are put in, all the observations are taken, and we start talking to the family to get some background information about the person who's arrived into the ER. As we talk, we have a policy of getting the CT scan done next on table. If, for example, if somebody is on the table right now, we would wait for them to finish it, and then the acute stroke patient will go on the table immediately after that patient. Anybody else who's waiting can wait. So the stroke patient is given priority, and as soon as the patient goes on the table, it only takes about 4 or 5 minutes to get a plain CT scan. And all we do is look for any bleed in the brain. If there is no bleed, and if there is no contraindication to use the drug, and if they are within the golden hour time window, which is 4.5 hours, we immediately deliver the bolus of the thrombolytic drug or the clot busting drug. And we are proud to say that our door to scan time is less than 20 minutes, most of our audited time frames, and also our door to needle time, which is the drug delivery after they arrive at our friend door, is less than 30 minutes. This is what I would like every other stroke treating hospital in the country to do, to have a regular audit on your door to scan time and also door to needle times. So as soon as the bolus is delivered, we run the CT angiogram to see where the clot is. Is it starting all the way from the carotids, or is it in the middle cerebral artery as the brain enters the brain, or it is in one of the branches, or whether it is in the posterior circulation where important brainstem structures are situated. So if somebody has a posterior circulation stroke in the basilar artery or a larger artery that's carotids or the major vessels, unfortunately, the clot buster cannot lyse it, cannot dissolve it. It only happens about 10 to 20% of time in carotids and about 50% of the time in the entry points of the blood vessels. So what do we do in those patients? So luckily, the technology has advanced now. So we have newer techniques called thrombectomy, where we can pass a catheter through the blood vessels. It's a minimally invasive procedure, and the clot is retrieved through a catheter which has got a stent in it. It's almost like a heart attack patient coming into emergency where they have a stent put into the coronaries. So yes, we have clear time windows. So if somebody is within 4.5 hours, have a large artery stroke, so we do the clot buster and bridge it with a thrombectomy, mechanical clot removal, if they still have the clot. Or if somebody is outside of the time window, we can still do the thrombectomy because, as I said, beyond 4.5 hours, the bleeding risk is higher with a clot busting medicine, but we can do a thrombectomy for them. So we do sort of quick scans to look at whether a person would benefit from these sort of procedures. Thrombectomy obviously is a very costly procedure. The catheters are all imported and the cost is is a little higher. So before we do the procedure, we need to make sure, even after opening the brain vessel, is the person going to improve out of it? So for example, if somebody has a good penumbra or not. So for example, as they arrive, a lot of our patients may not have a penumbra. So in those patients, even after opening the vessel, nothing significantly important improvement happens. So in those patients, we are actually wasting the resources or putting them in harm. So we would like to do these sort of scans where we look for collateral flow, meaning is the brain still perfusing and having a penumbra? And once the penumbra is confirmed, then only we take up for the next step. So in this slide, so just quickly recapping, 0 to 4.5 hours, we do a thrombolysis plus or minus thrombectomy, and 4.5 to 6 hours now we can go up to 8 hours. We can do a thrombectomy without the thrombolysis. If somebody has a basilar artery occlusion, we can extend the time window beyond 12 hours. So a week ago, she's still admitted in our hospital. She came in with a basilar artery thrombus, and they presented to us at 12 hours from onset of stroke. Because posterior circulation of the brainstem is very resistant to ischemia, we can still try and salvage the tissue. And if she had not been in our hospital, if she had not had the thrombectomy done, I'm 100% sure she would have been dead by this time. And I'm proud to say she is alive. She's about to go home today or tomorrow, and she is talking, walking, and the rest of the family are pretty happy. So this is a slide just shows how the blood clot is retrieved using a catheter. So in this slide, you can see the arrow pointing downwards. There's a blood clot sitting in the middle cerebral artery or the larger vessel into the brain. And this is an angiogram. The normal angiogram shows a complete filling up of all the vessels going into the brain. On the other side, you can see there's a absence of flow in the blocked vessel. After we have done the thrombectomy, you can see the filling is restored. So you can see the pre and post pictures showing restoration of flow. And restoration of flow means restoring the brain function as soon as the vessels are opened up. So, and we have, I've mentioned about the time windows and tissue windows, but there are a good proportion of patients who may come to us with unknown onset of time. So 25% of strokes happen during sleep, and we routinely see patients first thing in the morning who come up to a ER with a history that they woke up and they have a stroke. So in those patients, it's a little tricky. You cannot be sure about the time window, and luckily technology can help us here. So this sort of knowledge of the tissue changes in the MRI scans like DWI and FLAIR, and there are multiple techniques that we can use like CT perfusion, which can tell us whether there is still a penumbral tissue in the brain. So this is a very quick scan that we can do. A very quick MRI may take about 10 to 15 minutes to get a DWI and FLAIR. If the FLAIR is not showing any tissue changes, and again, this has been confirmed in clinical trials across the world, those patients are found to have a viable penumbra, and the bleeding risk with thrombolytic agents are lesser. So wake-up strokes can be helped with advanced technology and being offered with the latest treatment. And I'm proud to say we are doing this at our hospital. And as Dr. Bona said, in this pandemic time, we do see a lot of large artery strokes. And at the early stages of pandemic, there was a fear that people will contract the virus as they come to hospital, and there was a dip in the number of stroke admissions and TAA visits. But now the fear factor is gone, and we are seeing increasing number of stroke patients coming to the stroke centers. Uh, the recent trend that we observe is those who have a very milder disease, very mild illness with coronavirus, tend to develop hyperclotting or clotting dysregulation and immune dysregulation, and they present to us with clots in multiple sites, like vessels going to the limbs or vessels going to the heart and also to the brain. And unfortunately, we do see increased proportion of younger patients with large artery strokes. But this is not something we need to panic. Again, these patients are somebody who are known to have high risk factors like diabetes, hypertension, other lifestyle diseases. If they had been looking after their lifestyle conditions reasonably well, I'm sure they would not have ended up with a large artery stroke. So that's what we are routinely doing in our COVID patients. Routinely, all our stroke patients are screened for comorbidities at the time of discharge from hospital, and they are offered antiplatelets, or I mean blood thinners, and including stronger anticoagulants at the time of discharge, and they're followed up routinely in our post-COVID clinic to prevent such drastic complications. So I've talked a lot about ischemic stroke so far. This is the other 20% of strokes, which is the hemorrhagic stroke. Hemorrhagic stroke means a bleed inside the brain. It's often a more serious, a devastating type of stroke. The white, cloudy parts of the blood that's leaked into the brain, as you can see. So as soon as somebody comes to us, there's a bleed that is seen on the scan, but as the time goes on, the bleed may progress and affect major parts of the brain, because skull is a very tight sort of box. You cannot it cannot hold anything that is extra beyond what it should be, like brain, CSF fluid, and the blood that flows within the pipes. When it leaks inside the skull, it increases the pressure in the brain, and the high pressure in the brain can cause immediate loss of life. So our neurosurgery colleagues will be very, very helpful anytime, 24/7, to come in and decompress the skull and reduce the clot burden. And often we do procedures like drains into the cavities of the brain to reduce pressure. So this slide just shows a completely different type of stroke. This is what we call a subarachnoid hemorrhage. So here the bleed is not within the brain, it is outside the brain, but inside the skull, within the fluid spaces. So of all the strokes, subarachnoid hemorrhage strokes are the most devastating. Almost 20% of patients die before reaching hospital, and another 20% would die within the first few days of hospitalization. And they are often due to these aneurysms, little blood vessel outpouchings that you can see within the blood tree that we see inside the brain. And when they rupture, they can be devastating. And these sort of aneurysms are treated by coiling, which is a minimally invasive procedure, or surgically opening the skull and clipping the aneurysm. So just before I conclude, I just want to sort of highlight the concept of acute stroke ready hospital, because it's very important. Right now, not everybody who have a stroke ends up in a stroke ready hospital, and not all hospitals treating stroke patients are actually stroke ready. So if you go to America or Western countries, there is a certification that a hospital has to have, which says that they are a qualified advanced primary stroke care center. But unfortunately, we don't have that sort of setup yet in India, which I'm hoping should happen very soon. And these sort of stroke-ready hospitals follow a set of international and national recommendations in treating patients, right from the ambulance pickup in the emergency room, in the subacute period, in the first week until they are discharged home and they are followed up in the community. So a stroke-ready hospital should be fully equipped with stroke on-call teams. They should audit their door to scan and door to needle times periodically. They should have facilities to thrombolize, use clot buster and mechanical thrombectomy, and also have facilities to manage complications. Like if somebody has a bleed, how do you manage those bleeding complications? And all stroke patients should be treated in a dedicated stroke unit. So like all heart patients are treated in a coronary care unit. So same way, the outcomes of stroke patients can only get better if everybody are treated in a dedicated stroke unit, like what we have as a hyperacute stroke unit. And stroke is not a disease that can be managed with just a single individual. It is a multidisciplinary condition. You need inputs from physiotherapists, speech therapists, occupational therapists, psychologists, neurosurgeons, neuroradiologists, and so on. Again, a hyperactive stroke-ready hospital should have your EMS teams and local health bodies that are well aware of your services locally. So, ambulance crew who picks up a stroke patient should know which hospital they should take them to. So, going one step further, I would also like our bureaucrats and politicians to take note of what happens in the Western world. For example, in the US, there is a legislature that prevents patients getting treated in the wrong place. So, for example, if somebody wakes up with a stroke, they may go to a nearby hospital for first aid. And then from there, they may go to a scan center. And then by the time they get the report, the tissue window is lost, the thrombolysis golden hour is lost. So just to avoid this, there is a law in the states that each and every person who comes across, whether it's a primary care physician or a smaller nursing home or a scan center, if they have a stroke patient within the time window, they should immediately direct them to the nearest stroke-ready hospital or a certified stroke center. So if we can do that, I'm sure we can prevent patients presenting to us very late and missing out on the most important life-saving treatments. So let me conclude by saying let's get stroke aware and let's get the right stroke care at the right time at the right place. So many thanks for the opportunity, and I would conclude now, and I'll take some questions later. Thank you.
Thank you, Dr. Sivarajan. That was really interesting. Now we have Dr. E.S. Krishnamurthy, who will speak to us, who is a behavioral neurologist and a neuropsychiatrist. He is the president of the International Neuropsychiatric Association. He is the international academic leader with multiple professional affiliations in the field of neuropsychiatry, epilepsy, dementia, and public health. He has won the President's Medal of the Royal College of Psychiatrists, UK. He is the elected fellow of all the 3 Royal College of Physicians of the UK. He's published 70 plus peer-reviewed publications and 30 book chapters. He edits the Global Approach series of books for Cambridge University Press. He is a social impact leader in healthcare with a strong track record of community service. He is also the founder and chief executive officer of Buddhi Clinic chain, offering integrated and holistic brain and mind care. You can visit it at www.buddhiclinic.com. You can also read his Beyond Feeling Your Emotional Brain to understand better your brain and behavior interface. He'll speak on rehabilitation and long-term care. Welcome, Dr. Krishnamurthy.
Thank you, Lata, and thank you so much to the Hindu for this invitation. Thank you to my colleagues at Kauvery Hospital, Dr. Bhuvaneshwari and Dr. Sivarajan for giving us such a nice overview, and Dr. Aravindan Selvaraj also for his invitation to join this. I'm going to talk about rehabilitation, and I'll start by trying to share the screen. Just have a few slides to try and illustrate my points. So when Professor J.P. Morse, one of the world stroke experts, gave the T.S. Srinivasan oration in 2004 in Chennai, he said that only 4% of people make it to Columbia Hospital in New York in time for thrombolysis. And sadly, that situation continues, that a very large number of people do not come to hospital in time for stroke to be treated. I saw Sanjay Pinto and other people asking in the Q&A box, what are the symptoms? Well, here is the acronym FAST. If you develop a facial weakness, if you develop a weakness in your arm, if you develop problems with speech, then do suspect a stroke. The stroke is a brain attack. It's as good as having a heart attack, just attacking a different part of your body, really. And time is golden at this point, that you have to get to a hospital. And as Dr. Shivarajan has been pointing out, you need to get to a hospital on time rather quickly. And you need to get to a hospital that has the capacity to treat you. There's hardly a point, for example, going to a hospital that doesn't have a CT scan. Because if the first thing that people want to do if they suspect a stroke is a CT scan. And all our treatment decisions are based on simple things like that. So JP Moore said only 4% make it to Columbia and New York on time. Let me tell you that that statistic is not greatly improved. A recent survey showed that 25% of people coming for stroke treatment are eligible for clot busting. But even in the West, even at this point in time, only about 10% is on time. So one of the biggest problems why people have a stroke and end up with a disability is because they don't reach hospitals fast enough. Many of my patients have a stroke early in the early hours of the morning, or they wake up with a stroke. And then they say, oh, let me see, maybe I'll get better as the day passes, or I'll wait for my son to come back from office. And when you do that, sadly, the problem in your brain, the clot, or rarely the hemorrhage, can become bigger. And as the problem enlarges, the disability enlarges, and you're left with more problems that you have to deal with. So time is golden, and please remember the FAST acronym. Here it says 999, of course in Chennai it's 108. Now what does the stroke do? The stroke can affect pretty much every part of your body. Visual symptoms are common. Speech and swallowing are commonly affected. Weakness of the limbs is something that we see in a number of people. Problems with the bowel and the bladder are things that we see with people. And weakness in the legs as well as the hands are seen. Many people have other problems to do with memory, with thinking, with emotions, pins and needles. A lot of symptoms are part of having a stroke. So please remember, a stroke affects your brain, but the impact is on your whole body, and different parts of your body can be affected by a stroke, depending on which part of your brain is affected. Now, one of the things that we look at is what's called a DALY, or a disability adjusted life years after stroke. And what I want you to understand that that's got two components. One is years lived with disability, and the other, the years of life lost because you had a stroke. The stroke burden is projected globally to increase from 38 million DALYs in 1990 to 61 million DALYs in 2020. More and more people are living with years of disability due to a stroke. More and more people are losing years of life due to a stroke. What you see in the blue is the years of life lost, the curve. What you see in the red is the years lived with disability. Please keep this in mind. Now, what kind of disability do people have after a stroke? 60% almost have visual problems. And when they are evaluated 3 months later, 20% continue to have visual problems. 75% have an arm or a leg weakness. About a third have speech difficulties or aphasia. Please remember, speech has got two components. When you say a speech difficulty, it can just be a problem of articulation. You're not able to pronounce words properly. And we test this by asking people to say British Constitution or Rajagopalachari. On the other hand, some people have a problem of language production, and that is an aphasia, when the center for language in your brain is affected. And that can include both comprehension and expression. So it's much more than a mechanical problem of speech. Then, of course, many have problems with activities of daily living, and these include eating, chewing, swallowing, toileting, bathing, dressing, things that we take for granted, things that you and I do every day. please remember about a third end up with cognitive impairment, which means your higher brain functions are in some way impaired, and many actually develop dementia. And please remember that depression and anxiety affect over half of all survivors. So your disability after a stroke can be physical, it can be cognitive, it can be emotional and behavioral, it can affect your senses, and most importantly, it can be functional, which means that your activities of daily life are impaired and you need assistance for activities of daily living, which means life is no longer the same again. A very important reason why stroke needs to be taken seriously. I'd like to remind you about Sharon Stone, Basic Instinct. You know, we all remember her as a most attractive actress, famous for that scene. But do you know that in September 2001, she had a stroke? She had a form of subarachnoid hemorrhage. And she was in hospital for 9 days. It took her 2 years to recover, and it took her 7 years to get back to work. And she said she had to remortgage her house. And she actually said, I lost everything I had. I lost my place in the business. I was like the hottest movie star you know, she told Variety. I was like Miss Princess Diana, and we were both so famous. And she died, and I had a stroke, and we were forgotten. You know, and this is sadly the story of stroke, that it takes people a very, very long time to recover from stroke. And this is something that we have to keep in mind. It's very important, therefore, prevention, as Dr. Bhuvaneshwari was pointing out, early care, as Dr. Shivarajan was pointing out, both of these are important. But sadly, as I've been pointing out, most people have a disability with stroke. So where does rehabilitation start? It starts in the hospital ICU. It has to continue to step down in a rehab center in case you go to one. Most people don't. And at home, most people go home from hospital. Rehabilitation has to address physical, occupational, cognitive, behavioral, and functional disability. Therefore, it is a multidisciplinary effort. It's not one doctor writing a pill. It focuses on activities of daily life. It focuses on health-related quality of life. And most important, in a country like India, where it's not possible to sustain long-term rehabilitation, rehabilitation has to empower the individual, the family, and the community. Please remember, everyone can participate in some way for rehabilitation. I'll give you a very simple example. You know, people wonder, how can I help my relative who's had a stroke and who's lying in bed? Well, you can spend time with your relative. You can take turns to assist people in their activities of daily life. You can engage in what's called reminiscence, where you take out the old family album and look through the photos together with the relative. You point out various things to the relative. You try and get the person to respond to you. You can play them the songs that they like. You can play them the prayers that they like to hear. You can participate in that activity with them. So rehabilitation, therefore, is not just a therapist coming home to deliver treatment. It is about the family and the community be feeling empowered to participate in this activity together with the individual. And this is extremely important. At Buddhi Clinic, we believe that in addition to modern medicine, the ancient wisdom has a role. And we have certain very strong reasons why we believe this. The first, these traditions, ancient traditions, have lasted years and years and years. They predate a lot of what we call modern medicine. If they were not doing what they should do, they would not have lasted. The consumer would have thrown them out of the window. First point. The second point, the potential of these is great. There are many people who are capable of delivering these treatments, especially when they are properly supervised. And these treatments have potential to improve things that sometimes modern medicine struggles to improve. And therefore, it's very important we keep them in mind. Third, ask yourself, what are the barriers to healthcare? There's availability, there's affordability, there's acceptability, and there's accountability, the 4 A's. And of these, take acceptability. How many people would enjoy a session of Ayurveda? How many people would enjoy a session of reflexology? How many people would enjoy trying to do some yoga? And why not do these things together with your physiotherapy, your occupational therapy, and your speech therapy? And that's the question we ask ourselves when we set up the clinic and we have this multimodal approach to integrated rehabilitation. And one of the most exciting things that has come on board in the last few years is what we call neuromodulation. Neuromodulation is the use of magnetic and electrical impulses to stimulate the brain. And there are techniques called transcranial magnetic stimulation and transcranial direct current stimulation. EMS is not portable, TDCS is portable. And these are treatments, and therefore TDCS can go to the bedside. These are treatments that play a huge role in helping people recover. So, for example, people with post-stroke depression, people with post-stroke spasticity respond very well to TMS. Post-stroke motor weakness responds well to TMS. Whereas people with speech difficulties, they are often using TDCS on the bedside along with the speech therapy. So, in a sense, there is a lot that one can do as a rehabilitation. And of course, people do ask about the use of robotics and the use of more modern methods. Those have a role to play too. Sadly, they are available in the higher centers, which means that we have to reach them in the higher centers. And that comes with its own challenges. But all of those techniques have a role to play. So I'd like to leave you with the thought that rehabilitation can be enriched by combining modern medicine, modern science with ancient wisdom. I want to go back to the first slide because I think this is very, very important. We're all marking World Stroke Day. Please remember that if you end up having a problem like a weakness of the face, a weakness of your arm, a problem with your speech, especially if you seem to be waking up with it in the morning or you wake up in the early hours of the morning and you find you're having a symptom of this nature, please don't sit at home. Please get yourself to a stroke unit. It is exceedingly important. Thank you so much once again to the organizers for inviting me.
Thank you, Dr. Krishnamurthy. So there are quite a few questions here. Dr. Krishnamurthy has already answered one from Sanjay Pinto. There is another question here which says, what are the lifestyle changes that can prevent stroke? Ma'am, you're muted.
Could I answer that question?
Yeah, sure.
Yeah.
Yes.
We talked about prevention. I think audio. So prevention, we're talking about what are the risk factors for this particular person to have a stroke. So age is a factor, yes. Most of the strokes happen after the age of 55 or 50, so age is an important factor. But what are the other correctable factors? Here, this is where your lifestyle becomes very important. Now, if you look at the risk factors, the common risk factors, diabetes, high blood pressure, high cholesterol, your sedentary lifestyle, your diet, and also a very high family history of strokes increases the risk of that particular person having a stroke. So what do we do in terms of prevention? Now, the question is leading a very healthy lifestyle, including exercises as part of your daily schedule, eating a very balanced, healthy diet, making sure that if you have diabetes and blood pressure, making sure that you are keeping those factors under control with regular checkups and improving your lifestyle. So these are factors which you have control. So you need to be looking at what are the controllable or can be altered in risk factors. Of course, certain factors like the genetic predisposition or age is not something that we have control over, but definitely the lifestyle related risk factors are something that you can definitely control. Thank you.
You're muted.
So here's one question. Can clot busters be given to heart patients with some degree of stenosis?
Yes, it can be. So, and in fact, clot busters were originally used from the heart attack success. So, it is a straight extrapolation from treating heart attack patients who got better. Then we started using stroke. We still use clot busters for acute heart in my patients, and then they bridge with the primary sort of stenting procedure. So, yes.
Thank you, doctor. Here's another question for you. So somebody, Dr. Nalini Ramamurthy, she thanked you for the lucid overview presentation on stroke. And she wants to know, is it possible for a patient to have both HGIC, I don't know what that is, a HGIC stroke and ischemic stroke? So she
So
says,
I presume she wants to know if someone can have a stroke which is like a bleed related as well as a block in the blood vessel related, hemorrhagic as well as ischemic
oh,
at the same time. It is extremely rare to have both stroke types at a given same time. But if somebody has a bleed, then we would be very cautious. We won't be keen to use a clot buster at a time. But we can use the mechanical devices to reduce the clot, to reduce the stroke burden if they are in a larger blood vessel.
thank you, sir. There's another question. Why does stroke happen mostly at night? Is it related to circadian rhythm?
Yes, yes. There is a lot of studies to what happens. There are a lot of variations that happen during sleep. Um, a quarter of hypertensive patients have high blood pressure at night time. They're called non-dippers. Normally, when we go to sleep, our blood pressure falls and our heart rate drops gradually. But in certain individuals, the blood pressure is very high. And just before we wake up, at 4 o'clock in the morning, the blood cortisol levels, the stress hormone levels increase in our body. Just it's a natural evolutionary mechanism in the body that helps you to prepare for the day. When the cortisol increases, those who have a say a plaque in your major arteries, so like carotids and other places, they may have alteration in plaque, and the plaque may get easily clottable. And also there is a slight variation in our blood parameters, like we can get a little hyperclottable in the early stages of the morning. So our body is doing a lot of excretionary metabolic function, and you make a lot of urine before you sort of wake up. And because you're not been eating, drinking through the night, so you're slightly less hydrated. On top of that, you have these stress hormones building up in the body, and on top of that, if you have a vascular condition, diabetes, hypertension, and so on, then the increased stroke risk of is exceeded.
Can I just add to that as well?
Yes, ma'am.
Sorry. We're talking about sleep. Now, when we're looking at sleep, we have the REM sleep and the non-REM sleep. So, the non-REM means rapid eye movement sleep, and non-REM is the non-rapid eye movement sleep. So, a sleep cycle consists of stage 1, stage 2, stage 3 of non-REM sleep, and then you have the REM sleep, and they keep repeating themselves. If you look at the sleep cycle, the REM sleep, we see that patients go into REM sleep more so in the early hours. Their REM sleep duration increases during the early hours of the day. And REM sleep is a very dynamic stage of sleep. And like Dr. Shivrajan was saying, there are pressure fluctuations, changes in the hormonal states, changes in the way the blood vessels, the pressure inside the blood vessels, the rigidity of the blood vessels. All these changes happen during the REM part of sleep, which is maybe one of the reasons why patients have more strokes. Not only strokes, even patients can have heart attacks in the early hours of sleep, because more of REM sleep is found in the early hours. So that is a theory that has been proven over time with many various research.
Thank you, ma'am. Here's another question. What type of thrombolytic drugs are used to treat stroke in emergency? As all drugs are not I don't know, lipophilic, is it? And
Lipophilic.
lipophilic, okay. And can't cross triple eight, and there's some leader dots. I have no idea what that is.
Blood-brain barrier.
Oh, okay. So,
I think
would somebody please answer this?
there are, if you look at the types of, there are two major types. The earlier ones that were used, like streptokinase, and we don't use them in brain attacks or strokes. There are only one licensed drug in the world, which is the alteplase. But due to cost factor, uh, uh, various other issues, there are other drugs that have come to the market. The one that is widely used in India nowadays is called tenecteplase. There are two drugs that can be used, alteplase and the tenecteplase. You can hear me?
Yeah, yeah, I can hear you, sir.
So, yeah. And again, they have very strict dose and time limits. So alteplase is used at 0.9 milligram per kg, but do not exceed more than say 90 maximum dose. And tenecteplase is used at set time windows and also set dose windows. So there are very strict criteria as in how you use those drugs.
Okay, and how long should a patient be on? There's some echo coming. How long should a patient be on antiplatelet and anticoagulant for post-COVID-19 patient?
So it's very a difficult question because it's still evolving. The science behind COVID is still evolving. But in our hospital, we recommend at least about 2 to 3 months of antiplatelets, and we tend to use about 90 days of anticoagulants. We use drugs like rivaroxaban, apixaban, or dabigatran. Blood thinners are used for routine anticoagulation purposes like atrial fibrillation or hyperclotable conditions in the blood. So we use these stronger blood thinners in those who have multiple risk factors like ischemic heart disease, diabetes, hypertension, and so on. If they have no risk factors, we use antiplatelets again for 6 months.
Thank you, Doctor. Dr. Krishnamurthy, there are a couple of questions coming your way. When should neuromodulation therapy be given after a stroke? That's one question. And how does Ayurveda naturopathy work to improve brain function?
So to the first question, I think we always wait for a time of biological stability, which means when the stroke is acute and when the cerebral situation is still evolving, that is not a time that we choose neuromodulation. Neuromodulation is something that we use as a rehabilitation treatment once a certain stability in the level of disability and what's happening in the brain has been achieved. And of course, people have potential to improve for as much as 12 to 18 months after a stroke, or in fact, any form of brain injury, including traumatic brain injury. So it's therefore, it's a rehabilitation effort as opposed to something that's used in acute stroke care or even subacute stroke care. So mostly post-hospitalization is the answer. With regard to Ayurveda and naturopathy, the use of these treatments helps greatly with comorbidity. So to give you an example, Panchakarma procedures are extremely helpful in helping people. For example, there's something called Shirodhara, where hot oil is applied onto your forehead, drips onto your forehead, or Shiro Abhyangam, when it's massage onto your forehead and onto your head and your neck. Procedures like that are very helpful in improving metabolism, helping people feel relaxed, and certainly becoming alert and awake. One of the things that we've been doing is community-based projects where our mobile therapy units go and deliver treatment free to elders who have mental disability or children who have autism. And one of the uniform findings in our community-based research, which we've also written up about, is that levels of attention and the levels of calmness increase greatly. In someone who has a stroke, after a stroke is complete, a person is left with weakness, but because of the weakness, over a period of time, they will get other problems. For example, people get a frozen shoulder, they get painful joints, they have muscle spasms. These things respond extremely well to the types of massages and poultice-based treatments that are available in Ayurveda and in naturopathy. And of course, there are treatments like acupressure and acupuncture, which can also be used in post-stroke rehabilitation. I want to make it clear that all these are external treatments. We are not talking about giving people internal medication, and they are all used in a rehabilitation setting as opposed to an acute care setting. These are two different settings, and we must be very clear about that. They help in improving blood flow, improving metabolism, easing the stiffness in the muscles, and improving their joint functionality. All of which is very important when you're working with somebody who is already disabled because, in fact, disabled because of any condition, not just.
Thank you, doctor. Here's one question. The role of aspirin in emergency medicine. What is the role of aspirin in emergency medicine?
So, if somebody has come with a stroke and if they are not eligible for thrombectomy, the first line drug we use is a high dose aspirin. For example, if somebody has a mini stroke or a TIA, and they we use aspirin as a secondary prevention drug. So I would not use aspirin as a drug that commonly used when somebody has a heart attack. So, for example, we say if somebody is suspected of having heart attack, they can take an aspirin before they come to hospital. But we don't recommend that because if it is a bleeding stroke, it will make it worse. That's probably what the person is going to ask. Yes, we do use aspirin after we've done a scan to make sure your scan does not show bleed. And often aspirin is used lifelong in those who have multiple risk factors to prevent strokes.
Thank you, sir. One more question. Can sleep apnea trigger strokes?
I think this is an extension of the previous explanation I was giving you about the sleep and the various stages of sleep. Again, sleep apnea is a condition where the airway is a bit narrow, and as a result of which the patient has got history of snoring. And also, these patients, when they are going into deep stages of sleep, the airway just collapses. And as a result of which, these patients also have mild apneic spells where they may not completely get aroused from sleep, but their sleep pattern is very disturbed. So their sleep is not refreshing, and also they have daytime sleepiness. Apart from this, because of the multiple apneic spells that they suffer from, these obstructive sleep apnea has now been identified as an independent risk factor for strokes and heart attacks, and also for even blood pressure. When somebody has got high blood pressure, refractory to treatment, slightly obese with a tendency for obstructive sleep apnea, we look at treating the obstructive sleep apnea so that there is better control of blood pressure. There is also the reduction of the risk, an independent risk factor for hemodynamic strokes, both for hemodynamic strokes as well as heart attacks. So definitely yes.
Thank you, ma'am. Here's a question. I'm a teacher and a first aid lecturer. After identifying the facial weaknesses, arm weakness or difficulty in speech, we need to shift them immediately to stroke-ready hospital. There is no time for first aid. Am I right, doctor?
I think yes, she is right, because like Dr. Shivrajan was saying, see the difference between first aid for a heart attack and stroke is the fact that when somebody you think is having an unstable angina or severe chest pain, you can give them medications prior to coming to the hospital, an aspirin or an anti-anginal medication. Whereas in stroke, the scan becomes very important, because even as experienced doctors working in the field, looking at the patient, it is very difficult to differentiate between a hemorrhagic stroke and a ischemic stroke, that is a stroke caused by a blood clot in the blood vessel. And the treatment is completely different for a hemorrhagic stroke and a ischemic stroke. So the scan becomes very important. So getting the patient as early as possible to the hospital is important. And this is where identification of stroke, so that you know, if identified that this patient has suffered a stroke early, makes a huge difference. Now, with regards to this, we have the Stroke Association, World Stroke Association has actually given us this acronym for people to identify strokes early. It's called B FAST. Earlier, we used to have FAST. Now they've extended that and calling it B FAST. Now, each letter in this acronym stands for a sign of stroke. For example, B stands for loss of balance. So if a patient suddenly loses balance, not able to walk straight, then please think of stroke. Visual problems. I stands for visual problems. So blurring of vision or double vision. F stands for facial weakness. So if you find that the patient has got some facial weakness, is not able to speak well, arm stands for limb weakness. And S for speech. So if they're not able to speak well. So each of the letters stands for the sign of stroke. And when you see someone have any of these signs and symptoms, think of stroke, get the patient to the hospital immediately. And as Dr. Shivarajan was insisting, you have to make sure that they get to a hospital which is stroke ready, so that the appropriate treatment at the right time is given, and we can save this patient from having long-term disability.
Thank you, madam. There is one more question. Dr. Sivarajan, I actually posted it to you privately. I think this is a person who's 57 years old, and he had a stroke, and he seems to be stable in terms of how the brain is coping with is coping and regenerating the received immediate admission and help within the first few hours of onset, but was on a catheter and had a UTI that, that led to severe sepsis, gram-negative fungal cultures, which is showing as congestion in the lungs, but he tested negative for pneumonia, TB, COVID, as well as bouts of arrhythmia. What is the reason for arrhythmia? How lethal is it? What would this patient need right now to cope?
So the concept of hyperactive stroke unit actually is what I would like to say. So immediately, what we do in the friendo in the first few hours of stroke is to reduce the stroke burden. The first, from the first day to 7 days is what we call as subacute period. So where everybody who have a stroke should be looked after to prevent complications. So a lot of data shows that if somebody has a UTI, like urinary tract infection, or aspiration pneumonia due to inability to swallow food and fluid, and they can choke on their own saliva, those patients tend to develop sepsis. And if sepsis sets in, the brain can't heal well, and they can't get into the road to rehabilitation. So unfortunately, this gentleman has developed sepsis, gram-negative sepsis, but it can be treated with appropriate antibiotics. When somebody gets into sepsis, the body reacts to the sepsis in multiple ways. It can drop blood pressure, it can put stress on the heart. Um, so if somebody has a pre-existing heart disease, they can have what we call as arrhythmia or atrial fibrillation or ventricular arrhythmias. So coming back to the arrhythmias, atrial fibrillation is a irregular heart rhythm condition that increases with age. 10% of patients, people in the community, more than 10% of people above 80-year-old will have atrial fibrillation. The risk of AF increases if somebody has a heart condition. So I doubt he probably may have had pre-existing heart condition, and that is predisposing him to develop arrhythmia when he is undergoing sepsis. So the arrhythmia can be easily corrected again with appropriate drugs with the help of cardiologists. There are multiple medicines that we use. but he doesn't have to panic. Arrhythmia can be corrected. His heart can be sort of optimized. Sepsis can be controlled, and he can be taken to the road of rehabilitation sooner. Yes, arrhythmia on its own, if you look at strokes due to cardiac arrhythmias like atrial fibrillation, the clots that happen in the heart due to atrial fibrillation are larger clots and they cause large artery strokes. And the fact that they are there means that the atrial fibrillation is the risk is higher and persistent throughout the life, and it can cause repeated strokes. Those who have atrial fibrillation and cardiac arrhythmias. So those patients are those who would benefit from long-term blood thinners, what we call as anticoagulants.
Thank you, doctor. So here again, lots of people have asked, how do we identify if a person is going through stroke or if he's going to get a stroke? That's one question that's been repeatedly being asked. Another person has asked, mind depression can be a cause of stroke, or can it cause stroke? They've asked.
So if I probably should try and answer the question on depression. Depression is a very interesting condition because it has a bi-directional relationship with a number of neurological conditions. Epilepsy, Parkinson's, dementia, stroke, in a sense, therefore, that we do know that epidemiologically, depression sometimes precedes the development of these conditions by years. But depression also follows the development of these conditions. One of the reasons why a person who's depressed may develop a stroke, especially if they have other risk factors, is because when people are depressed, their lifestyle usually becomes extremely poor. So they don't sleep very well, they don't eat very well, they stop exercising, and they will, in all probability, aggravate their risk factor, which may be pre-existing, or they may even develop risk factors if the depression is prolonged. So this is something that one has to keep in mind. Even more importantly, I think, since we're talking rehabilitation, post-stroke, depression can be an impediment to getting better. So post-stroke depression can be the single most important factor that prevents a person from achieving optimum quality of life after a stroke, or being able to achieve the recovery milestone, because they feel demotivated, because they lack confidence, because the depression itself makes them feel unable to do things which they might otherwise be able to do. In other words, it's not a motor weakness that they have, but a functional disability that's come on because they're depressed. So I think it's extremely important to be able to identify depression and treat it. And depression is not uncommon in the elderly. Today we know that there's a whole, a lot of data today about late life depression, that people do become depressed in later life. And they, of course, already are in the risk range for stroke because of aging, because of cholesterol deposition and hardening of arteries, and because of a range of other risk factors, because age itself is a risk factor for stroke. So I think that's a relevant question to be asked.
Thank you, doctor. So there's one question here. Is burning feet frequently, does it have anything to do with brain stroke? I don't know. I think he means burning sensation in the feet.
That could be because of another problem called neuropathy, and diabetes, which is a very common problem that we see in our country, can cause, it puts you at risk of having strokes and heart attacks, and also it gives you neuropathy because diabetic is a metabolic problem. So because the sugar is not very well metabolized, there are some toxic substances which are released. They can cause nerve damage and cause neuropathy, which causes burning feet. Usually, the common factor between burning feet and the strokes could be diabetes, but direct influence on stroke risk, no, doesn't do that.
One last question. Please explain the role of estrogen in clot formation.
I think that's a very important question, because if you look at the incidence of strokes, you will find that younger women before menopause, the chances of women getting a stroke before menopause is definitely lower compared to men. So definitely the hormones, estrogen and progesterone, they do play an important role in terms of protective mechanism. And you will see that there have been various studies to prove this as well. And in fact, after menopause, the lady, the chances of getting stroke is almost similar to a man. So the menopause, the hormonal status in the body definitely gives you a protection when it comes to both strokes as well as heart attacks. Yes, it's sometimes good to be a woman.
Thank you, ma'am. There was a question here about which gender gets lots more stroke. I think we are coming to the end of this seminar. Thank you all so much for being part of the Hindus webinar series. We had a wonderful session. Thank you very much. There are quite a few questions. Maybe they will just forward it to you so that you can answer them. Thank you.
Thanks.
Thank you so much.
Thank you, Sujata. Thank you, Dr. Bhuvneshwari, Dr. Sivarajan. And thank you to the audience for being so interactive.
Thank you. Thanks a lot.
Thank you, Dr. Krishnamurthy. Thank you, Dr. Sivarajan. Thank you, sir.
From the moment of entering this world to the silver years with challenges of a different kind, to situations of trauma when the entire family needs support. Over 300 specialist doctors across 50 specialities cater to patients from the region, other parts of India and overseas. When genuine care meets state-of-the-art technology, one certainly feels better and then heals better. Kauvery Hospital, a trusted name in healthcare. With 5 key centers across Tamil Nadu, Kauvery Hospitals offers clinical excellence and world-class infrastructure in a myriad of disciplines. There's a 24/7 imaging services and a futuristic cath lab.